So I'm pleased to be with you all today. Thank you so much for the work you do, first and foremost, and for spending the time here today to harmonize together. I'm grateful to be with you. I'm from the Penn State College of Medicine. I'm going to be doing a duet today with Jen Barborak, which I'm very excited about. I'm in a small band in the Hershey area, and yesterday we did a performance of Leonard Cohen's Hallelujah, which many of you may know. And in it, there is a line, the major falls and the minor lifts. And I think Jen and I will be doing sort of a version of that today. I'm going to be giving you the minor fall, talking a little bit about despair. And then Jen is going to be giving you the major lift, talking about some of the really exciting work that she's doing in Mercer County with a community health hub, a digital hub that we've collaborated on. So I'm very excited to sort of seed you all with ideas and then hear your ideas as well. So let's start with the minor fall here. So we don't hear about this on the news so much because we're flooded with culture war all the time, but we're in the midst of a public health crisis of falling life expectancy. So since the Spanish flu in 1918, life expectancy has risen about 2.5 years predictably each decade. And so we've seen this stepwise rise for most of the US history, but in 2014, even before COVID, we started to see a dip in life expectancy, which was anomalous. No other country in the world is really seeing this sort of trend. So there are a lot of factors driving this, but at the heart of it are what researchers have started to call deaths of despair. These are deaths from 3 types of afflictions: chronic liver disease, you can see the green line there, suicides, and accidental poisonings, mostly from opioids and not synthetic opioids. And when researchers first looked at the rise, astronomical rise in these deaths, they noticed that there's a particular demographic, which is white non-Hispanic men and women in middle age. That cohort from about 45 to the mid-50s was disproportionately affected, and rural America was really the sort of canary in the mine for these conditions. Just to give you a reference point, in 2021, we suffered about 209,000 deaths of despair in the US. In the 1990s, we had about 60,000. So we're really increasing, unfortunately, in a dramatic way. When the researchers have studied deaths of despair, they've looked at death certificate data, and there's a line on death certificates about educational attainment. And they found that one of the biggest predictors of a death of despair is having a bachelor's degree or not. And if you're a man or woman and have a bachelor's degree or more, it sort of serves as an inoculation, a vaccine against despair. But this crisis of deaths of despair and falling life expectancy is really a crisis of the working class in the United States. And I'll touch a little bit more on why that might be in a few moments. So while this crisis did initially start in rural America with the demographic that I mentioned before, we are more recently seeing a spread to other groups. So for the first time in 2022, we saw deaths of despair rates that are higher for indigenous communities and Black communities. A lot of that is due to fentanyl entering the drug supply in places like the Northeast. But we've also seen an anomalous rise in suicides for Black youth, which we're not entirely sure why that's happening. And there's also strong data to show that local employment perturbations are affecting Black American drug mortality as well. So I mentioned the numbers again. You can see the actual rise from the 1990s to about 209,000 deaths of despair in 2021. And just to give you a sense of the regionality, these conditions tend to affect people in the Rust Belt and in Appalachia and also in the American Southwest. So anywhere where there's been a sort of loss of industry, automation, these are all factors that are driving this condition. And I want to just very briefly talk through this because the story of deaths of despair is a story of the downwardly mobile middle class, a working class that's just not making it in the way that they used to. And this has been driven by a lot of factors: globalization, the outsourcing of jobs, automation, robotics, the fact that unions have been attacked, for the last 50 years. And we've had a shift from an industrial economy to a service and knowledge-based economy. And if you don't have a bachelor's degree, it's a lot harder to make it in the middle class in a service and knowledge economy. Right? So the odds are just increasingly stacked against people who don't have those cultural resources. So these material shifts in the culture over the last 50 years have basically stagnated wages for the middle class. Community fabric has frayed, as we all have felt in small town America. There's been higher rates of divorce. Men are less marriageable. People are less participating in social institutions. Religious institution attendance is down significantly. We've had a reduction in social safety nets, and so on. We live in a very low trust society these days. And generally, the social contract that governs America, which is that you will do better than your parents' generation and better than their parents' generation, has sort of reversed for this generation. That is fueling a sense of despair and a loss of hope and forward-looking bearing in the future for many people. And that's producing despair, and people are trying to escape from or numb the despair they feel. And there's obviously an unfortunately high supply of opioids circulating in the culture, cheap alcohol, gun ownership. So these are providing means for people to progress to diseases of despair, and unfortunately about 209,000 deaths of despair annually. Just to give you one example from our region, this is Steelton, Pennsylvania, which is just in the Harrisburg area, south of Harrisburg. Steelton had a major Bethlehem steel factory. It employed in the 1950s about 9,000 people. Today it employs about 350 people. Right? So you have a dramatic loss of jobs in that area, and people trying to reinvent themselves and find their footing in a different type of economy, in a post-industrial economy. And it's going to create catastrophes and social consequences for people. And again, I don't want to, well, I guess I should blame our politicians, right? They're kind of the ones who have orchestrated these trade deals. And this is both sides of the aisle, deals like NAFTA and other trade deals that have allowed jobs and money to flow all around the world and out of the United States. So to get briefly into some of the community engaged work that we've been doing, with Dr. Krasniewski and others in this room, we've partnered with Highmark to look at areas in the state and in the region with high diseases of despair rates. These would be clinical manifestations before they convert to deaths of despair, people going to their doctors for suicidality and addiction issues. And we published our findings a few years ago in the British Medical Journal. And just to give you a very quick look at this, we found that 1 in 20 insurance carriers in Highmark reported a disease of despair from 2009 to 2018. And we had a 68% increase in diseases of despair overall during that time. You can see the dotted lines are people with Medicaid plans. So again, working class folks, people on the lower end of the income spectrum are disproportionately at risk, both men and women. We've done focus groups in some of the hotspot areas that we identified in this work, and some of the groups have been in both rural and urban areas, and we saw very convergent findings that we published a few years ago, with people identifying financial distress, the lack of living wages, the lack of benefits in jobs, lack of job training centers, infrastructure to get people to jobs, and so on. And we saw this real alignment between perspectives in rural America and urban America. So a lot of people are feeling the despair and the material drivers of that despair. Other work that we've done has concerned rural hospital closures. This has been another major issue in the United States. We've had over 100 rural hospital closures since the early 2000s, and you can see them mapped here. In central Pennsylvania alone, we've had about 6 in the last couple years, these institutions that are closing. And one of our medical students at the College of Medicine studied the effects of these hospital closures on other hospitals within the area of the closed hospital. And he found that there were substantial economic consequences for those remaining hospitals because they took more emergency room and other hospital admissions visits, which aren't necessarily financially positive for the institutions. So it's putting the hospital closures are putting a major strain on the bystander hospitals in those areas. And the student, Cheyenne Ramadani, did a really beautiful video that's on YouTube. If you search Closed Doors, Shot 664, he did a drone flyover of all of the closed hospitals in the region and put a very moving musical score to it. Just a very, very nice aesthetic way of showing the collapse of these institutions. We've also worked with a cardiologist and with Highmark to show that people with diseases of despair also are disproportionately at risk for cardiovascular disease. So we're finding that heart disease is also a key part of this problem. We partnered with the College of Nursing at Penn State and Blueprints, which is an addiction recovery facility in Elizabethtown, Pennsylvania, to study with people in active recovery what their moment of clarity was. What was it that allowed for a metamorphosis that kept people from converting to a death of despair? And we're hoping to find different patterns in that data that we can use to help others who are in that precarious position. We've also worked with Fayette County to do economic development. They've sort of thrown their hands up at the lack of political efforts in the county and are trying to do grassroots economic development to sort of give people more dignified lives in the region. But I'm very excited to hand off for the major lift part of this talk, now that I've flooded you all with despair this morning, to hand off to Jen Barborak, who has led with the Buhl Regional Health Foundation a digital health hub. And Jen has done just fantastic visionary work with that, and I'm excited for her to share her work with you all today. Please welcome Jen.
Thank you for welcoming me to your community. I was asked to come here today to talk to you about a CTSI community engaged research project that we participated in and talk about how we engage stakeholders and our community, kind of to go with the music to create an orchestra from a group of soloists. I'm the executive director of the Buhl Regional Health Foundation, and I consider myself a community volunteer, a collaborator, and a problem solver. I'm a proud Penn State Shenango graduate and a registered nurse with a bachelor's in environmental science and a master's in nonprofit program evaluation and grant writing. As a community organizer, I've identified problems in our community, and I envisioned and created a few nonprofit organizations to help solve those problems. My work as a registered nurse has found me in the fields of surgical nursing, urology, and emergency nursing in rural and urban hospitals in Mercer County. I spent time as an environmental scientist focused on water quality issues, and in a different role, I used geospatial software to identify gastrointestinal cancer incidents related to the location of environmental contaminants in Mercer County. So I kind of am a jack of all trades. My role at Buhl Regional Health Foundation, though, is why I'm here today. Buhl Regional Health Foundation is a private foundation, and we're located in Mercer County, Western Pennsylvania. Our foundation envisions a healthy county where people are active participants in driving their health and the health of their community. Recently, because we view prevention as key to improving the health of our community, we strategically added a youth health focus, and we have been including in a kind of a research, community engaged research project, their input into our processes. And that's something that we actually learned from our CTSI team is how to do that. Our work related to our vision includes providing grant funding to community youth health-based programs, providing scholarships to the youth graduating from high school who wish to pursue health-related careers, and creating programs to fill the health-related voids that we are finding in the community. We also assist organizations by providing them with the tools they need to meet their mission. I assumed the role of executive director in the fall of 2020, mid-pandemic, and I immediately began working to connect community organizations who could assist individuals who suddenly found themselves in quarantine but had never needed to use community resources. Through that work, we created several initiatives and networking groups. Then our foundation staff joined several others that we found in the community. We made so many connections within the community that we soon became known as the key organization that was trying to learn all and piece it all together related to the general health of Mercer County. More importantly, over the course of a few years, and by changing the way we were perceived in the community, we developed strong relationships with our community-based organizations and the health facilities. We began working with our grantees as partners, not just organizations we were funding. We dress casually when we go to site visits, and we meet them on an even playing field, and we're willing to share our resources with them. We also understand that many of them are volunteers, and they don't have grant writing skills or reporting skills, so we work with them to help them improve their applications and their reports. And we ask them how they would like to measure success, and we work with them to develop their strategies for success. We revised our reporting to only include meaningful questions that we need the answers to, and we record those answers as data. I began meeting nonprofit CEOs casually for breakfast or lunch, being curious, asking questions, learning, and listening. And I began reaching out specifically to new female nonprofit CEOs, and we created a little group to ask questions of each other, share advice, help each other through the rough times, and celebrate the wins. Our foundation created an outreach campaign that included radio and TV commercials, health chats on TV, and educational health ads in newsprint and magazines, all branded with the Buhl Regional Health Foundation logo and tagline. Trust building in a community takes time, effort, and visibility. After over 3 years, I believe we're finally considered the key collaborator and leader for health-based organizations in the community. We are such a trusted organization that with the help of Dr. Garrow, the CEO of Primary Health Network, Buhl Regional Health Foundation was able to convene in the same room the CEOs of our local hospitals, Sharon Regional Medical Center, UPMC, Horizon Jameson, Allegheny Health Network, Grove City, and Sharon Community Health Center, which is our FQHC lookalike. This team, that includes the CEOs of competing health facilities, now meets quarterly to review community health needs and brainstorm projects that might improve the health of the community. We're not talking Medicare, Medicaid reimbursements. We are talking looking at the county health rankings and determining what we can do. One thing has become very clear. The health of a community does not correlate to the number of hospitals in that community. Instead, the lack of connectedness between hospitals and social service organizations seems to have more bearing. After all, last year, Robert Wood Johnson Foundation ranked us 58 out of 67, so we're right there with you, Schuylkill. We have 3 hospitals, the FQHC and the FQHC lookalike. So that's where the idea of a digital hub came into play. The Community Health Task Force, which is the CEOs of the hospitals, met for over a year. We brought in social workers, community health workers to gather information and learn about the health needs of the community. Foundation staff and I continued to meet with all of the groups previously mentioned. And everyone we were talking to was saying the same thing. We know that there are ample resources in this community, but we don't know what the resources are, and we don't know how to access them. Organizations were spending countless hours compiling spreadsheets and handbooks in an attempt to publish the resources available in our county, but the information was outdated before the hard copies even hit the public. Social workers complained that they would spend hours calling different organizations for their clients, only to find that the resources they needed were no longer being offered by a particular organization, requiring yet another phone call to another organization. It was a frustrating process and wasteful of their time. The Community Health Task Force learned about this digital tool, the Hub, and it's a searchable online dashboard that allows the users to enter a client's specific needs, returning to them a list of the resources and how to access them. We learned about a Hub's benefits during one of our meetings, and the idea of creating the Hub was accepted by all on the Community Health Task Force as a potential way to improve the health of the community. We met with several different types of hubs, but we weren't sure how to move forward. And that's where we enlisted the help of Penn State's CTSI and Dr. Danny George. Dr. George suggested, ask the community. So his team helped us create a survey that would determine several things. Does the community need to be more connected? Did the community-based organizations want to participate in a digital hub? What barriers might arise that would make it difficult for them to use the hub? Did they have the capacity to participate? What might measure the success of the hub? And how would the hub need to function? Would it have to have a phone answered by a live person? Would it need to be viewed on mobile devices, iPads, computers? And what kind of reports might need to be made available? The CTSI team and Dr. George also helped us determine a viable survey distribution plan. What would be a good number of responses? What would be a good cross-section of the community as far as respondents? Would we accept paper surveys? Would everything have to be done online? And how would we get the survey out to the community? At the same time, Buhl Regional Health Foundation applied to the Taproot Foundation, and we received an award from their Talent for Healthy Communities program, and that paired us with 5 Johnson & Johnson Company employees from all over the world. And if any of you are nonprofit organizations in this room, please go to the Taproot Foundation website. They have an excellent program that pairs nonprofits with different companies. With their expertise and that of the CTSI team, we distributed the survey to over 130 of our connections in the community. We have a relatively small community. I think our population's around 105,000. So 130 organizations is a pretty substantial group for us. Those connections included community-based organizations, school nurses, social workers, community health workers, county agencies, church programs, too many to list. I might preface this with the fact that 3 years prior, right when I first started, Buhl Regional Health Foundation attempted a similar survey, not quite as robust, to about 50 community-based organizations. We received 6 responses. This time around, because of our community connections, their trust in our foundation, their trust in the professionals that we had enlisted, CTSI collected over 100 responses. They compiled and organized them and conducted preliminary analysis. The results were then sent to the Johnson & Johnson Company team. The data analysts at Johnson & Johnson used the results to determine that the community wanted and would support a hub, that the organizations did have the capacity to utilize a hub, and the requirements for a hub in Mercer County. Because of the foresight of the CTSI team to ask survey questions related to the functionality of the hub, the Johnson & Johnson team was able to put together a requirements document, and they began meeting with different types of hubs. And from those interviews, they determined that our county could simply buy into an already existing hub model, find help. Because Buhl Regional Health Foundation is a trusted partner, the CEO group determined that we should be the ones to take the lead and have our logo on the hub. As such, we gladly assumed the costs. What better way to improve the health of our community than to further connect the services and the resources? From our standpoint as a major health funder in the community, we look forward to having the ability to see where the overlaps and gaps in service are. And we as a funder hope to use that information to create our requests for proposals and even new programs to address the needs that we're finding. We are also setting aside funding to help the organizations with costs associated with joining into the hub. And we're currently working with Find Help to develop the dashboard, a marketing plan, and an onboarding plan for those organizations. The cost for us to have our neutral, community-based, community-trusted logo on the dashboard, assist a little bit with the management, but most importantly, have access to all the information collected on the back end is roughly $25,000 a year. An additional $10,000 is needed for startup costs. To improve the health of the community, that's a minimal investment. We have learned that community-engaged research cannot happen without earning the trust of the community partners. And trust is not earned overnight, nor does trust building ever stop. At Buhl Regional Health Foundation, we're currently learning, and we're documenting this project in such a way that we'll be able to share with you next year, if I should be invited back, what went well and what we might do differently. But the one thing I can tell you we definitely would do again is work with Dr. Danny George and the Penn State CTSI team, because they provided valuable insight into the project, and without their expertise, we would still be spinning our wheels, possibly even backpedaling on this important project for the health of Mercer County. Thank you. I'll bring Danny back up, or Dr. George.
Thank you, Jen. And I guess this is the part of the talk where we open it up for the symphony to come forward from you all. Any questions or comments?
I have two questions that are related. Question number one, so you are, you are creating the hub, or you are using other platforms that are already hubs, and then you are jumping, just adapting to your project?
What the team found, the Johnson & Johnson team found, they interviewed 6 or 7 different hub platforms from across the country. And then they also looked at the possibility of us building one from the ground up, which was, I mean, it was going to be a substantial cost, probably $75,000. And what they found is for us to build the hub, it wasn't what we truly needed, and it was going to take a lot more time and effort. So from the hub models that they researched, Find Help seems to be, it's a model that anyone can actually, it's already up and functioning in multiple counties across the country. As a matter of fact, I believe Allegheny County currently uses it out on our side of the state. And so it was a natural connection for us, was to go ahead and simply buy into using that hub. The reason that we're putting a little bit of money into that is because anyone can use Find Help, and it has the Find Help logo, or it might have Find Help and Allegheny Health Network logo, Find Help UPMC logo. In our community, the hospitals compete. And so if one of those hospitals would have said, oh, well, we'll put our logo on it, or just the hospitals would have said, oh, we'll put our logos on it, I don't think it would have been as trusted for the community-based organizations. So we stepped up and said, let's just put our logo on it, at least for the first few years, so that the community-based organizations, when we go to them and say, hey, will you upload your information, that the hub does not work without the community-based organizations keeping it updated constantly and ensuring that their information is checked off and is accurate. And so the person applying into the hub for the resources is looking at organizations in real time. Those organizations have their programs continuously updated on there, so that there's not a program on there that has been outdated for 2 years. it's kept up. And so that is the capacity that we were worried about with the community-based organizations, is them being able to continuously update that information. And a lot of the back-end research that we're finding is that the community-based organizations are so frustrated with people not knowing what their services are that they're willing to take the time and effort to buy into this hub. But so I guess that's why I wrote my speech, was because I really get long-winded. That's a long answer to your question, but we're simply paying to put our logo on a dashboard that the community-based organizations and individuals will be able to see.
Thank you.
Hi, I just wanted to make a comment off of your question. So St. Luke's, I'm from St. Luke's, and we do have a Find Help platform. I know that United Way also has 211, but we do have instructions for any community organizations that would like to be part of the Find Help. And I have some cards here as well. I know Lehigh Valley, I don't know if anybody is here from Lehigh Valley, but Lehigh Valley also does have Find Help. It's actually really good for the health systems because it's connected to the electronic health records. So if someone comes into the hospital and needs some services, they're easily able to make referrals. And it's really important for your organization to have their correct information and Find Help. So thank you so much for bringing that up.
That's a nice harmony there.
Yeah.
Just want to echo some of the comments there. The Department of Human Services in Pennsylvania has launched the PA Navigate initiative. That is through the Find Help platform. So that is a big push here locally as well, getting community-based organizations to really buy in and update that. So it is a widespread system. I think we're familiar with it. And then also with 211, as mentioned before, I think we have robust systems in place here that we're starting to have these conversations and look at those closed loop referrals, that conversation between the healthcare and those social service agencies, and making sure people actually follow through with those referrals and such.
Time for one more if anybody else has a comment, question. Oh, here we go, back here.
You had mentioned a resource that local nonprofits could connect with the larger companies. Can you share that resource one more time?
Oh, the Taproot Foundation. I'm so sorry. Yes, it's Taproot Foundation, and if you go to their website, they have it's a program that's open all the time, and it's a very, very quick. There's two different types of grants that you can receive through them. The grant that we received was an extensive grant. It's only offered 2 times a year, and it's international. But they have a platform where you literally fill out 3 questions and submit. So if you need help with marketing, or you need help with HR, or legal, anything like that, they have companies that they will connect you with. And it's free. The work is pro bono. It's usually something that can be completed in maybe 6 weeks or less. We recently used them for our other research, our youth-based survey that we've put out into the schools. And we put this survey out into the schools with open-ended questions. What were we thinking? We should have called Danny George for that one. But then we got all of these results back, and we didn't know how to pull them together. And so we applied to the Taproot Foundation, and it was 3 questions and a brief description of the project. And within 6 hours, we had 3 different marketing and data analysis companies reach out to us. We interviewed them. We chose the one that we wanted, and we worked with him for about 5 weeks. He pulled all of the information together for us and then taught us how to do it so that we can do it on our own next time. But it's an excellent program. You have to be a nonprofit to apply to them, but I highly recommend it.
Thank you so much. What a great discussion.